re-expansion of the lung after surgery.
All right. Good morning or good afternoon from, I think it's still good morning, right? From Orlando. Thank you, Dr. G, for having me here. And actually, it's been an education working with you over the years. And I've had to obviously read a lot and try to understand the physiology, the pathophysiology, and the surgical skills and the surgical techniques involved. Because I've always believed, as an intensivist or as a physician involved in post-operative care, it makes a whole lot of difference if you make an effort to understand a little bit, not quite as much as the surgeons, but at least to have an idea what really goes on during the surgical procedure. I'll try to avoid getting into the definitions because obviously my data in terms of what is referred to as a large hernia is approximately 70 years old. So I'll defer that definition and the controversy surrounding it to the surgeons. You know, from our perspective, most large hiatal hernias, using the traditional definition, are mainly paraesophageal hernias. And they're either, the type 1 or the mixed type. And a lot of them actually come in with a little bit more than just the stomach in the intrathoracically. And unfortunately, too, a lot of those patients come in, in their later years of life for surgery, either because it wasn't done much earlier or they start having more symptoms as they get older. As one of my colleagues mentioned earlier, things like atrial fibrillation obviously will happen a whole lot more, and maybe the final push to get them to agree or to seek for surgical intervention. The interesting thing, though, is that older patients, yes, may have a higher morbidity and spend a little bit more time, in the hospital following surgery, but they actually do pretty well in terms of quality of life following surgical intervention. And also, they do not have a high mortality from the surgery. So in essence, yes, they may look old, yes, they may stay longer in the hospital, but it's definitely very beneficial to offer them surgery because it's safe and clearly improves the quality of life and avoids the other complications. So how do you move to the next slide? I've seen it here. So again, I'll try to avoid getting into the controversies regarding the size and definitions of hiatal hernias. Most hiatal hernia surgeries are done electively when the patient becomes very refractory to medical therapy and have major symptoms, which include dysphagia, early satiety, postprandial pain that could either be abdominal or chest, and actually mimic angina pains, persistent vomiting postprandial, anemia from bleeding, and of course, severe dyspepsia, which some of them describe in very graphic terms in terms of what it makes them feel or how they wake up at night, gasping, can't breathe, and with very severe chest pain. It can also be done rarely emergently for acute volvulus obstructions, strangulation, perforations, or respiratory compromise. Prophylactic surgery at this point still remains, controversial. But if you think about it, I'd rather have a surgery when I'm 40 than wait till I'm 80, because obviously my mobility and my length, and being able to, at that point, you're more likely to have more comorbidities than when you are younger. So in essence, it may make more sense actually to have them done at at an earlier age. Preoperative evaluation, it makes a whole lot of sense for the post-op physician to somehow acquaint himself with the patient. It's very reassuring for me as a physician to be able to have seen the patient preoperatively, to have an idea, how things looked before surgery. And also, the patient feel very comfortable meeting you and knowing that, yes, you'll be involved in my care following my surgery. There are some very salient things I always try to define. One is to very clearly define what their current symptoms are. Is it dysphagia? Is it chest pain? Is it postprandial vomiting, nausea, atrial fibrillation? and also try to have an idea what the previously attempted therapy was in terms of any prior surgeries, or was it just medical therapy? And then dig as much as possible to elicit all comorbid issues like cardiac or pulmonary diseases. This may involve seeing a cardiologist to have a detailed stress test, echocardiogram, and from the pulmonary perspective, we try to do a pulmonary function test. And of course, they would have done a detailed GI evaluation prior to being scheduled for surgery. Very important. I mean, I really can't stress this enough. I just call it a very robust personal review of the X-ray imaging. Not just the report. You've got to take a look at the images yourself and have an idea, what the size of the hernia is, what the other contents beyond the stomach are, and have an idea, the extent of any pulmonary atelectasis, which obviously will factor in your post-operative care. And also, use of chronic pain medications may look like it's not such a big deal, but you have to remember that for the first day or more, the patient will be unable to take anything by mouth. So in essence, you have to have a very clear plan what to do. Because if you already have a chronic pain issue, then you may run into problems with withdrawal and being able to control their pain following surgery. Also, other substance abuse like alcohol, smoking may also factor in as well post-operatively. So it helps to be very clear whether these are present before the surgery. Ongoing tobacco use, we all know, affects the rate of atelectasis in the post-surgery, and it helps to have an idea whether this is present as well. Some patients, if they have the kind of the right risk factors, you have to worry about OSA and trying to evaluate them if you have enough time. The surgical approach, obviously, I'm not going to kind of delve into it as much because obviously I have more people who are more knowledgeable than me. But the fact of the matter is, yes, it's robotic. Yes, it's minimally invasive. But if you kind of look at the video that we watched a few minutes earlier, that tells you how deep they dig into the thoracic. It's almost like having like a thoracic surgery trans-abdominal. And unfortunately, too, we don't seem to quite often appreciate the amount of dissection involved, the amount of scar tissue involved, and the amount of disruption that you have to think about that will determine and direct what you do post-operatively. Very rarely they end up as open, but mostly it's all done laparoscopically with robotic assistance. The transthoracic one obviously will have a much longer stay with frequent need for chest tubes and mechanical ventilation. And definitely the pain management becomes very crucial. Then the reduced surgeries or past history of any kind of upper abdominal or thoracic surgery will suggest presence of very extensive adhesions, which would kind of affect the length of the surgery and may end up pushing to an open approach. And this also will affect what you do post-operatively. So the immediate post-op considerations is always going to be, where do I put the patient after surgery? Are they simple enough, well enough to go straight to a medical floor, or to go straight to like a regular post-surgical floor, or would they need ICU monitoring? Well, first, it depends on obviously your local availability of ICU beds and the experience of both the ICU team and the non-ICU crew. And more importantly, really, is to have a very close relationship with your surgeon, because each case, you may plan initially the patient may go to the floor, but then he goes in there, finds it's a little bit more complicated than he thought it was going to be. So you've got to listen to your surgeon, you've got to work very closely with him and respect the fact that, only he knows how complex it was during the surgery. And that would help direct where the patient ends up being placed post-operatively. Clearly, presence of very severe comorbidities and extreme age also will factor into your placement. The length of the surgery, amount of dissection needed with significant bleeding or not would also affect what you do afterwards. and any intraoperative incidents which you'll be made aware of by the surgeon and by the anesthesiologist in terms of airway management, ease of placement of endotracheal tubes, and any other cardiovascular incidences that may affect what you do afterwards. And of course, if you need to be on a mechanical ventilation, which become very important with real large, with presence of intrathoracic, stomach, spleen, and other abdominal organs with very much significant atelectasis, because if you do not do that, you very likely will end up with the lung staying collapsed and with more obvious chance of more complications. Also, patients that require very excessive opiate needs preoperatively, you have to remember that post-op, to give that much, they can't take PO, to give that much IV will clearly affect your patient ventilation. So you have to have other plans in place preoperatively to help you with taking care of that. So what do we really do when they come back from surgery? Very important to minimize your fluid administration, because yes, you may just give fluids liberally just to maintain blood pressure or whatever numbers you want to keep, but other fluids would affect patients' ventilatory capacity. And you've got, we found a very judicious use of diuretics when appropriate has been very helpful too. Most importantly is to minimize your opiate administration. Because if you think about it, as some of my GI colleagues mentioned earlier on, they have esophageal dysmotility, delayed gastric emptying, which all gets worsened by use of opiates. So we tend to try to optimize pain control with a mixture of local anesthesia. We use Presidex, which clearly has a lot of advantages in terms of pain control, anxiety control, without really affecting the GI function or affecting your respiratory status. Some patients actually do well with ketamine as well. For the same reasons, it will give you fairly good pain control without depressing your respiratory function as well as having any GI side effects. Toradol may come in helpful, but unfortunately, due to its GI side effects, effect on the post-op bleeding and kidney function, you have to be a little bit more careful with Toradol use. And then using IV Ofemev, that's IV acetaminophen or Tylenol, has been very helpful as well. And Robaxin, and whatever you may have locally. So the key point really is to try to avoid opiates as much as possible. Presidex has an extra advantage that for most patients who have a very chronic opiate use, it tends to lower the amount of opiates they need for that first few immediate post-op period. So it comes in very handy. Yes, it may look expensive, but by minimizing your GI side effects, specifically gastric emptying and GI dysmotility, it may actually save you a lot of time and money in the long run. So again, as my surgeon, Dr. G kind of clearly pointed out, intraoperatively by using a double lumen endotracheal tubes with selective lung ventilation leads to a lot of atelectasis. So yes, they do some bronchoscopy before they leave the surgery, but we always try to set them up for bronchoscopy before they are extubated. So that way you do a fairly good pulmonary toilet and clean the lungs out, particularly for those patients with long-standing hernias with chronic atelectasis. Because yes, the bronch may look invasive. In the long run, it's much easier way to re-expand the lung and avoid any pneumonias. And of course, you try to enforce your strict early ambulation and encourage incentive spirometry as well. The DVD prophylaxis is always standard, unless there's some major bleeding. Again, we try to kind of, while they're still in the ICU, you get daily chest images, which helps you to evaluate for need for extra bronchoscopies, and at some point, some patients may actually need some other interventions, either to relieve some pneumothorax or to get some pleural fluid off. The earlier you do it too, the better things will be in the long run by avoiding any pneumonias. Once they leave the ICU, the next day post-extubation, they get a barium swallow to assess the GI, the gastroesophageal junction, and then it will help you determine, when to start your PO feeding. Then as I said again, the long-standing hernias that have a delayed gastric emptying and motility issues may actually benefit from use of motility drugs. And then you have to have an experienced dietitian as part of your team to help you with dietary instructions. And we try to gradually get them to start oral liquids and slowly progress as tolerated. Then the chest tube monitoring and daily assessment for prompt removal as soon as feasible. Before they go home, we kind of work on their home health care needs. Some may require oxygen if they have other comorbidities, and they have very clear follow-up plans with X-rays if needed, and re-emphasize the limit on how much weight they're allowed to carry, and then set realistic expectations clearly in terms of expected slow resolution of their symptoms. And yes, it's very infrequent, but slight chance of recurrence down the road. And then dietary instruction with very low residue diet for a few weeks post-discharge also is very helpful. And try to get them some adequate pain medications to go home on discharge, and plans to remove any tubes that may have been left for various reasons. All right. Thank you, guys.